So that's cardiac cycle. Now, have you gotten that part with Dr. Holmes did?
Yes.
We got to be in this. Yes? Okay.
So the heart has its own. The heart has its own blood supply. The endocardium has very tight junctions between the cells, so that blood does not pass through the endocardial layer into the myocardium. So you have different vessels that supply the heart. They are all branches of the ascending aorta. In fact, the only thing that comes off the ascending aorta. You have a right coronary artery and a left coronary artery right up underneath there. You can't see it real well. I got a better picture of it. But you can't see it real well. Then the right coronary artery makes its way around the heart. Left coronary artery is a little short, like that, and splits. It gives you the anterior interventricular, anterior descending artery, and the circumflex coronary artery. And then these arteries make their way around to the back side of the heart and come together and make the posterior interventricular artery. Now, there are a whole bunch more little branches of the coronary artery. But unless y'all change specialties and decide you want to go to medical school and be a heart surgeon, I'm not going to make a big deal about all those little branches. And the reason I'm not is because everybody's heart is different. Your heart is different from my heart. Your heart is not different from mine. Yours is different from mine. And a lot of it has to do with how active you are when you walk. Because your coronary arteries can undergo what's called angiogenesis. And I know you've read a little bit in the material about embryology. But angiogenesis is the development of additional arteries. You know, when you're in utero, it's developing arteries, everything's developing right along. However, when you grow up and you're out in the world moving around, your heart is obviously pumping blood all the time, or you'd be dead. So you're sitting in a chair right now doing nothing. It don't need a lot of money. But however, I'll take you up Boston today, and y'all decide to jump in here and run this Boston Marathon this morning. And tough for nine. But anyhow, as I told a guy, he's a retired Marine veteran. He's running his 500th marathon in Boston. Pretty cool. He's probably got to be in the 60s. I'm going to ask him. I have a patient who, in his 70s, who actually runs these, what they call passions, like 1,500 miles. This dude's in his 70s. No. But what happens in response to this, you have to have more blood supply to the myocardium. So you develop additional arteries. And you can see right here coming off this anterior ventricular, you can see all these little branches coming off right there. And they all have a name, depending if they're big enough, they're little tiny ones don't. But they're named for where they're at and what they supply. I've taken hearts out of cadavers that you couldn't even see the myocardium because there was so much extra artery supply to help supply the myocardium. I imagine that person was a marathoner. We don't have those issues about them, but I imagine they are very active. So, but now, with that said, if you got arteries, you got to have veins. So right here, you have the great cardiac vein. It makes its way over here and becomes the left cardiac vein. Then over here, you have the right cardiac vein. Making its way around the back and makes up the middle cardiac vein. And then this great cardiac vein and left cardiac vein come together, make their way around, join the middle cardiac vein and the right cardiac vein and form what's called the coronary cycle. And that empties into the right atrium right there. That's how the blood is supplied to the myocardium makes its way back to the heart. All right, so there's a little kind of, I don't know how to do it. Now, let's look at the inside of the heart. a heart and a penis in you,
No.
the same as your heart. Right. Got Sam, maybe actually read the material. So is the heart the same?
No.
No. What's the major difference? Well, just keep it simple for now. The major difference between your cardiac circulation and the fetus's cardiac circulation.
The fetus has a S-shaped tube for a heart instead of an actual
Oh,
four-chamber.
that's heart too. Yes, absolutely do. Frame of valves. What's different about the frame of valves? What's different? And why is it? What? I can't hear you. I'm seriously have to be honest. Well, that's what the umbilicus does, but you're on the right track. Over here, we have heart tubes. Absolutely right. The heart develops upside down. The atria are on the bottom, and the ventricles are on top. And as things develop, they change places. But in utero, the blood needs to go to the lungs. Any reason blood go to the lungs whatsoever? None. Exactly. To the ground. So there's no need for blood to go to the lungs. So what happens is, when blood returns to the right side of the heart, it's just immediately shunted over to the left side through the foramen of the valve. And the fossa of valves is where the foramen of the valve is from. And goes through the circulation, picks up oxygen at the placenta, and that's what the fossa ovalis is. And the foramen ovalis is the bottom of the fossa ovalis. Now you have another structure right up here. But it's not foolproof, so not all blood will pass through, but it trickles down into the ventricle. So you got a structure right up here coming off of the pulmonary trunk. That's called the ligamentum arteriosus in an adult. In utero, it's just a little extra piece of artery. And so any blood that does make its way into the right side of the heart will make its way up through the pulmonary trunk and over into the aorta. Just kind of a backup. You don't need that anymore. So it turns into connective tissue. And of course, Socrates and I don't know who else was involved in this, didn't have the same rules about ligaments we do. So they called it ligamentum arteriosus. That's a fetal ring. That's also a landmark for a structure we talked about last week. What is it?
Oh. That's the membrane that keeps it in place.
One of the landmarks we talked about last week.
I don't remember.
I can probably just go read an example of this right. What is that landmark? I'm going to go to the chest of the land. That's what that is for become ligament. Hey, remember the left pharyngeal nerve? Branch of the vagus nerve. Talked about that last week. Loops around this structure and makes its way back up to the larynx, so you can speak. You've done it right there. Right. One thing, but fine for you to all right. So now let's get in a little bit more detail. So there's our fossa ovalis, the foramen ovalis is there at the bottom. Foramen ovalis is closed, to be closed in the adult, again, what you're born. Closed maybe a couple of days after, but it's so blood comes back over here to the right atrium. Now right here on the inside of the atrium, see how smooth it is? except for this little piece right here. It was a whole, we had the intact parts, you can see, come down a little bit further, that's not right. And they're called the pectinate muscles. And does give the atria just a little bit of ability to contract. At rest, the atria doesn't do much. You kind of sit there and relax it, well, it doesn't do much. But when you're up moving around, certainly running or doing something active, those pectinate muscles are contributing a little bit to what's called the ventricular buildup. And you have them on both sides. And you also have a little extra kind of saddlebag right in here, and I got a better picture of it. We'll see. So right there, right over here. You have a little extra piece of tissue right over here called the arc, just like it here. Allows the atria to have more room. Whenever you are at activity, so the blood can return and more room. Make it back there. No, just a little sack. Right now, you're not going to use your arc. So it doesn't do anything much. But now here you have, between the atria and the ventricle, you have a valve called a tricuspid valve. And I got pictures of the valve up close in here in just a minute. Has three parts. Now you see how the valve is kind of angled down into the ventricle. So the blood moves from the atria down into the ventricle. And the valve is what helps direct that blood flow. When the valve closes, blood can't move back up into the atria. But sometimes that valve closes. It closes up like this, right? Everything's all right. Well, sometimes that valve goes back up into the atria, maybe enough to leak a little bit. That's called prolapse. Now, ideally, that doesn't happen. Here's why. Because right here, you have these little tiny muscles, and you got over here too, called papillary muscles. Now, attached to those papillary muscles, you have what are called chordae tendineae. And what they do is stabilize the valve, so the valve does not go back up into the atria. So it just comes together and closes. Yes.
So the valve kind of prolapses into
That could be. There's a lot of different things. So valve closes. Keep blood flowing back in. It makes you away from it. When y'all talk about the cardiac cycle, Dr. Hahn. So that valve closes up and prevents blood from going back to the atria. Like I was saying, sometimes it doesn't close exactly right. It comes up like this and kind of comes up into the atria. And it'll make a little clicking sound. You know, called prolapse. A lot of times it happens over here on the right side. I don't know why it's predominantly mitral valve. Mitral valve only has two cups instead of three. But a lot of women, young, especially young women, have some. And it's not uncommon at all. Generally, some I don't know, over 50 women. I think probably one of y'all probably has one. You know, and it doesn't matter unless it's real bad and the blood actually gets up so far in the atria, the blood goes back through the atria. No. EKG is the electric factor. Why you brought that up? We're going to talk about that in just a minute. But it will show up with a stethoscope. You'll hear it click. And if you have this going on with the heart, a lot of times bacteria like to get on these valves that are prolapsing and damage the valve. So I don't know if any of you have ever had any dental work, and the dentist actually listened to your heart. That's why they were listening to your heart. Because if they hear this, they go to a lot of times they'll go, if it's a major procedure, once you go to cardiologist to get checked out. But that's why dentists will actually prescribe antibiotics prior to dental work, is in case you have this problem. Because whenever this gets, you get an infection in there, bacterial infection, called bacterial enterocolitis, and you may go out to the, well, to treat it or be done. That's why they prescribe them. So our blood's going down in here into the right ventricle. Now you see all these little ridges in there. You gotta remember this, right? Allows the heart to expand, right? The heart to expand. So that's just the myocardium kind of folded up on itself. You have the same thing inside. But in the myocardium, in the ventricle, is called the trabeculae cardium. Now, right here is the interventricular. It separates the right side from the left side. Then the blood passes from the right ventricle through the pulmonary valve up into the pulmonary trunk. And you see this valve is angled differently than this valve. Just to direct blood flow through the pulmonary trunk. The valves are there to direct blood. Now what causes, let's see, what causes the tricuspid valve over here on the right-hand side, right there? What causes that to open? Because you say, oh, I'm going to open up. Blood flow. But what directs the blood flow? Now, pepillary muscles keep it from it. Gravity? What if you're on the moon? Yeah, a little bit. No, I'd weigh about 50 pounds. No, so what about these two astronauts that spent 9 months in space? So, exactly. So, how do their blood get down from the atria down to the ventricle? Relaxation. I get relaxation and pressure. So which one is it? All right, so what happens, the ventricle contraction, right, drives cardiac function. So the ventricle is inside. They create a vacuum. It allows the interventricular valve, the tricuspid valve, to open. And that vacuum opens the valve, plus draws the blood down from the atria. All right, so now how does the valve flow? How does the valve flow? Well, that's what I. So how does the valve flow? Pressure. What kind of pressure? Yeah. It causes compression. The ventricle contracts, and the pressure of that ventricle forces this valve flow. And that's what the chordate and the pathway muscle of the ventricle is. Going back up to the agent picture, popping back up. So the contraction of the ventricle closes the AV valve. But now you got this pulmonary valve sitting right up here. Now it's angled the other direction. So the same contraction of the ventricles that close the AV valve opens the pulmonary. And the same relaxation of the ventricle that opens the tricuspid valve closes the pulmonary valve. So it's all pressure, but it depends upon what pressure. So, how many of you ever had your blood pressure taken? All right. They gave you two numbers, right? Top number systolic, bottom number diastolic. When the ventricle contracts, that's called systole. That's why it's the higher pressure. When the ventricles relax, is called diastole. That's where the lumbar comes from. Because the arteries, everything working right, should be contracting roughly the same as my heart. It should. Sometimes it does, but it should. So we have relaxation of the ventricle, creating a vacuum, brings the blood down from the atrium. Now, that causes about 90% at rest, about 90% of ventricular tone. So you do have these pectinate muscles on very contracted to move the and then the ventricle contracts, shuts this valve, opens this valve, and pushes the blood to the lung. Yes, sir.
I know that high blood pressure has a lot to do with weight, or it can be hereditary.
Yeah.
Why does this have a lot to do with weight? It's also hereditary. You need not go to blood.
And here's why. Because I've got a little bit of the same issue. There is a genetic predisposition to have hypertension. A lot of it has to do with kidney function. A lot of it has to do with the way your arteries are configured, that sort of stuff. Weight. The reason losing weight will help hypertension is because the longer that tube is, the more pressure it takes to put blood through that tube.
And that's more like that has to travel.
Absolutely. That's why it takes more pressure to push it through that tube. Now, I have seen numbers, and I don't know how these numbers are arrived at, but I've seen numbers that we have 50, 60,000 miles capillary in the body. So, say you lose 10 pounds. I don't know, you're losing, 10,000 miles capillary. Just pull the number out there. I don't know where that came from. I don't know anything. But if you have shorter vessels, you have less distance to push blood. That's why losing weight won't help do that. Now, does it matter if it's fat or muscle? A little bit, yeah. It's not as much as most people like to think, but it is not. Because you have a lot more blood, more capillaries in the muscle with active tissue than you do in fat. So, you got somebody that's, I don't know, 220, 30, 40 pounds. They're 10% body. So they're not overfat, for sure. Not at all. But they may have hypertension because they've got all this other tissue that you still have to feed. So from a cardiovascular standpoint, it does make a difference. It's extra length of blood vessels. Now, there's a whole lot of things that factor into that, obviously. But from just a pure length of vessels, it's not going to make a whole lot of difference. So, back to this. Yes.
So is it reversed? Like if you look at muscle versus fat, or if you lose fat, you're shrinking the unnecessary, and if you're losing muscle, you're losing what you need.
Yeah.
Like somebody who's obese obviously needs to lose fat, so somebody who's muscle doesn't need to lose. Say they got an injury or something.
Yes, exactly. They're going to have less muscle tissue to feed, and it is going to make an effect on blood.
Okay. And when you say it shrinks the ventricles, it's not shrinking the heart; it's just shrinking the tubes.
No, I'm not talking about the ventricle. I'm talking about the blood. The tubes.
Okay.
If the ventricle is central, we're going to get that in just a second. We're going to get that in just a second. Sounds like I'm going to have to spend a little more time with cardiac physiology. That's okay. As fine. So, now blood makes its way up through the pulmonary arteries out here to the lungs. Now, before I go any further, look at the myocardial wall over here, and then look at the myocardial wall over here. The left side is much thicker than the right side. Why is that?
Lower trauma to push blood.
Do what?
Lower trauma, it's a lot of pressure, so less pressure. And the rest of the trauma needs to.
Yeah.
So blood is pumping through the body, but
absolutely right. The right side is just going to the lungs. What is that? Maybe 18 inches. I'm 6'1", so 18 inches probably. Not all I am left. Left side's pumping out through that 25,000 miles or whatever happens to work out to be. And yeah, height does factor in a little bit. That's why your resting blood pressure is so low. Oh yeah, absolutely. All right, let's take a break here. We'll come back. I'll be back at 10 o'clock and we'll proceed on.
This was the
that area out, it's not just right.
Sorry.
Hey, have you seen the movie, the Civic movie? Have you seen the Civic movie?
Partially, yes, partially.
You can probably see.
Hey Robbie, is that one new? Your forearm? I just haven't seen that before.
It's now summer, so I'm wearing shorts.
Gotcha, okay.
I was wearing sweaters and stuff.
Understandable. It's officially summer, now we know.
It is.
Cool.
Almost.
No, it doesn't want to give it up just yet.
No.
It's too cold.
Just wait. Give it another month.
Yeah,
It'll be very cold.
I hear it. Oh yeah, that'll be fun. How's Easter?
Sorry? My, Emma doesn't want to celebrate, so.
You're what now?
Emma doesn't want to celebrate, so.
Oh, gotcha.
My parents went to New Mexico
Okay.
for work.
Oh,
And I was like, I'm sitting over here. So I was
good, quiet, and restful.
yes, I got a lot of work done actually. So.
I wish I did. I tried to get work done at least 3 times, but I ended up getting not as nearly as much as I should have. But I got enough done to celebrate myself.
That's good. That's good.
We need to work. We need to work.
Better than no work.
Hey, we need to work on that. Just to get things done. I tried to do a bit of neuro, but that was agony. So the very first thing I did when I walked in here, I was talking about how I was doing that, and I got axons and dendrites. The very first thing.
Quiz?
No, just by saying it out loud. Axons are the long ones, dendrites are the short ones. I got that backwards.
Yeah.
Very first thing in school.
At least you find yourself.
Yeah, well, no, I didn't. Savannah taught me. And now I know better. Oh man, it's not that it's difficult. It's just that there's so much they're throwing at us from so many different angles that it's I don't know where to focus.
Yeah. This class especially.
This class?
What?
This class? This is one of the good ones.
I disagree.
Really?
Because that first week, like, really confused me. Not like what it was just like what we were supposed to know.
Yeah. And is this the one? This isn't the one where he posts it like 1 week at a time, is it?
No.
Okay, good.
Post it to week 4.
Yeah, no. I was gonna say that's also so we get the reading done. So speaking of that midterm, how do you think we're gonna be able to start? Just reread all the chapters?
Read all the chapters, probably. I mean, that's probably going to be your best bet. Also, probably the PowerPoints.
Yeah, the PowerPoints are not bad. The PowerPoints, in my opinion, so far are more like talking points rather than point pad and gesture. So, okay, just these are the pages we needed from the book, right? The links he has here. They didn't look like that. I think so. I don't know. I was asking you because I clicked on one of the links and it's definitely different than what was in the textbook because I read the textbook or part of the textbook. Yeah. Hey, Gabby, do you know if you go into the anatomy?
There's a lot in the city and outsourced them. The area where you're supposed to be, the most of the time.
We still got a bunch more to go.
This joke I'm about to make.
All right, so let's think we finished up right here with the pulmonary trunk of the pulmonary. All right, so over here we have the blood returning from the lungs to the pulmonary vein into this left atrium. Left atrium is basically the same thing as the right atrium. Right atrium does have one opening back in it, the left atrium does. It's called the opening for the coronary sinus. That's how the blood from the myocardial tissue returns back to circulation. Now I've got a picture to water down the line. So here we are. Oh, there we go. All right, here we are in our left atrium. Okay, blood just kind of comes there, just kind of hangs out. And then the myocardium relaxes. Okay, I'm just waiting. All right, the myocardium relaxes and opens what's called the mitral valve. Now, this is also an AV valve between the atrium and ventricle, just like the tricuspid is. However, this one is different. It only has two parts, not three. It's only a bicuspid. Otherwise, everything's exactly the same. And the blood, during the diastolic phase of ventricular activity, the ventricles relax and bring blood down from the atrium. The AV valve opens up, blood comes down to the ventricle. Ventricle contracts, causes the aortic valve open, allows blood to go out into the ascending aorta. Then, remember, aorta is an artery. So arteries pulse. They contract. There's a layer of musculature in arteries called the tunica intermedia. And that's what causes the arteries to have their pulse. Think the right hand of your wrist, you feel your pulse. Every artery, all the arteries in your body do exactly the same thing. A little bit more forcefully in some than others. But the aorta is doing the same thing. So, the myocardium contracts, forces the aortic valve to open, forces blood out into the ascending aorta. And then the ventricle relaxes. Aortic valve closes. Back creates a vacuum just like it does on the pulmonary valve. Creates a vacuum just like it closes up the pulmonary valve. It closes up the aorta. But the aorta being an artery, a little bit, it contracts all by itself. So once that aortic valve closes, where the right and left coronary arteries are located. So the right and left the aorta contracts and forces blood down to the right and left coronary arteries. And then out through the cardiac circulation. And those coronary arteries, they contract, but they're real small, so they're not going to have a whole lot of contraction, but they do contract. And so that's what's called the cardiac cycle. Now, it looks like I'm going to teach a little more physiology than I had planned. Oh, that's okay. Every time the right ventricle contracts, the left ventricle contracts, right? But do they work independently? All or nothing. Just like any other muscle. I'm contracting my bicep. You contract it up. Both hands, you contract it up. Myocardium is the same way. So if the right side's doing something, the left side's doing exactly the same thing. Unless there's a problem. If there is, what time do you not do as well? A lot of times it's a heart attack causing you probably can't do that. So their left and right side are doing exactly the same thing. Although this is pushing blood out through the body, this is just pushing blood over the field. Now every time the heart contracts, every time the ventricle contracts and push blood out, the amount of blood they push out is called stroke volume. And I think Dr. Hamden probably mentioned that. And you have another concept called cardiac output. That is stroke volume times heart rate. So how much blood your heart is pushing out in the course of 1 minute, as you would with your back. All right. So if you want to decrease the amount of blood that your heart is pumping out every beat, what's the quickest way to do that? Decrease it. Well, to decrease it, just roll it off. Can you change stroke volume? Yes. Yep. Take some time. It doesn't change overnight. It takes a few months. It's called Scarlet Law of the Heart. How many of you would consider yourselves runners? Marathon runners, half marathon runners. Okay. Well, as you train for that, what happens is the myocardium becomes more tight and it stretches. That will increase your stroke volume. So you're able to pump more blood. That's why someone who is a runner has a lower resting heart. Because it doesn't need to do as much to maintain proper blood flow. That's why if you find somebody who's a marathoner, their resting heart rate may be down as well. Well, yeah, that's a whole different ballgame. I think it would more likely not be better. I don't know that it would ever be as well as Cleveland because they need to see something going on with the high thousands and things. So the neurotransmitters don't need there's another, the two neurotransmitters that are the basal ganglia that produce. Dopamine is one of them, the other is who comes in the second? Who comes? I forgot. This ain't CNS. This is this. Well, dopamine also affects the GI. All right. So if this becomes more pliable, it can pump more blood, right? Stretch makes it larger, push more blood out. So you have what are called baroreceptors right here in the neck. And right here in the artery that detect blood pressure. And if the pressure is too high, then baroreceptors are immediately going to, via the vagus nerve we talked about last week, going to try to slow down heart rate. Baroreceptors, right? Barely. They're going to try to slow down heart rate. That's the quickest way to decrease blood pressure, decrease cardiac output. Now, there's a lot more to it than that. We talked about ours, we'll talk a little bit about that. But the vessel also, dilate, make the vessel larger so the blood can easier kind of fluid. There's a lot more to it than that. That's kind of the first step. And you all can do this, on your body. Take your reading pulse. And press here on the side of the neck, just one side, not both, shows my feet. Press on one side. And the brainstem thinks that the blood pressure is going up. And you actually feel a heartbeat go down. All right, so here we have, I told you to talk about that. So here we go. Just showing the blood patterns through the heart. Let's talk about that. Okay, so now, what tells the heart what to do? The brainstem, yeah, partially. Will your heart beat without a brainstem? Absolutely. Yep. Because the heart has a property called autoarrhythmia. People have brainstem all the time and end up being on respirators and whatnot because the heart just doesn't notice how weak. Now, a lot of times it won't be all in a few hours, but it will be all by itself. Because the heart is what's called autoarrhythmia. Each one of these myocardial cells, I know you're talking about depolarization of document, and each one of these myocardial cells can depolarize all by itself. It doesn't need anything else. It doesn't need all the cells in it's going to depolarize. It'll do it all by itself. And it'll propagate that depolarization from one cardiac cell to another through what's called intercalated discs, full opening between the cells. So if you propagate that, actually present. However, if you're doing that and you're not controlling it to some degree, it's just going to be all over the place, right? It's kind of, okay, we're contracting here, we're contracting here. And you'll experience that sometimes. When you feel like your heart does a little flip-flop, a lot of times you feel like your heart kind of flip-flop once, doesn't do it. It does a bunch of times, probably. It doesn't do it. Passive mode, out of whack, all of that. But, so you got to have something to coordinate that. And that's what the cardiac electrical system does. There was an old Indiana Jones, one of the Indiana Jones movies. They were down in a place, they were having some kind of weird ceremony. The priest reached in this guy's chest and pulled out his heart and set next speed. Feel that? So you have some neural tissue up at the top of the right atrium called the sinoatrial node. And when you hear on TV talk about a normal sinus rhythm, that means that the rhythm of the heart is right being set by the sinoatrial node. So the sinoatrial node depolarizes. Then the depolarization makes what calls the both sides. And then we come down here what's called the atrioventricular. The atrioventricular node causes a little bit of delay. So the ventricles can relax. Otherwise, the ventricles do not fill. So the AV node, well, I'm talking millisecond. To allow the ventricle to relax. And the blood to draw down from it. And then the depolarization wave passes through the structure of the muscle. And then you go down to either side of the artery and what's called the right and left bundle branches. Down the very bottom. Then you have what's called the perfusion. And that's what trains the depolarization through the tissue. And that will do work all, as long as you're, hopefully as long as you're alive, and sometimes you have a heart attack, or you cause a heart attack. But that goes on throughout your life. Now, if you have somebody that's a respiratory disease, somebody's, you know, dead, they're not an animal playing stress in that. That's happening 1%. Now, let's go in here very easily, get your heart rate up to 150, 150, no problem without any kind of anything else. It'll be about 75, 80% of blood. So how many times does that happen if your heart rate's 150? 3 or 4 times. And hopefully without pain. So just think about how quickly it takes. Whenever you see me in Fort Porter or in the lab, I have a segment set up on the antibodies table that shows the polarization of the part. Shows the depolarization rate. All right. So now, somebody asked me a minute ago about EKG. EKG measures the electrical activity of the heart. That's all it does. I take that same EKG sheet, go on your forearm, and measure the electrical activity of the flesh of the heart through the fasciitis. And then that's what EMG, basically it's called EKG is and EMG is all it measures the electrical activity. Does not talk about any of the mechanical functions. You can infer certain mechanical functions, but it does not really talk about mechanical function. With that said, if someone has a larger ventricle, does EKG, we all see EKG. Those EKG waves are going to be higher because there is more muscle depolarizing and more electrical activity. Now, also with that, kind of one of the things, if you're using a completely EKG, which is what you're going to see in the ER, or that's what we're all. Are you measuring the electrical activity of the left side of the heart or the right side? Who thinks it's left? Who thinks it's right? Who wants to use it? It's actually both. But you're only seeing the right side of the heart. Because, see how much less myocardial tissue there is over here? So you're seeing the electrical activity of the left side of the heart. You're still measuring it, it's still there all day long. But you just can't see it because it's overridden by the left side. Now you can configure the EKG leads in a certain way so that you can see what's going on with the left side of the heart. But you have to configure the leads. It's kind of hard to do. And with echocardiograms, you don't really do it. They leave echo and see what the heart's doing. If it's space.
But with that, when they have to do an EKG, they put most of the sensors on the left side.
Yeah. That's what you're measuring it. You can change that. But you probably never seen it done because the only time you do it, you're trying to see what the right ventricle is doing. And most of the time, they're trying to worry about what the right ventricle is doing when someone has something to pull it. So if the right ventricle gets enlarged, left ventricle gets enlarged, because like but you can also enlarge because of hypertension, right? Trying to push more blood through the arteries. It's going to have to, it's just like any other muscle, it works harder, it's going to get thicker. Right side doesn't really have a whole lot of resistance to blood pressure. Somebody asked me a second ago. Okay, so our arterial blood pressure, 120 over 80. Everybody's familiar with that. Our pulmonary blood pressure, 30 over 0. There's almost no restriction of blood flow through the blood. First of all, it's only 18 inches, maybe. you go down. Don't want anything restricted. Can it be restricted? If it is, it's always pathological. If something restricts blood flow to the lungs, the right ventricle will. So right ventricular hypertrophy is absolutely 100% pathological. Folks who have breathing disorders, I mentioned COPD the other day when we talked about the lung. Anybody with COPD, anything in the beginning of COPD, a lot of times experience hypertrophy like this. Now, the way to treat that is treat the underlying cause. Sometimes it's a vascular issue. And what to treat that with is by Viagra was actually developed as a treatment for what's called pulmonary hypertension. That's what it was for. And you had these old guys taking Viagra for their pulmonary hypertension. And all of a sudden, other arteries started dilating. And different things were happening. And so they realized, okay, this not only works on pulmonary arteries, this also works on these deep arteries, amongst others. And so then they went back to the approval process and approved it for use to attack. It's also used to treat what's called Raynaud's phenomenon. Some of y'all may have them where you hold 50 fingers turns white. That's an autonomic nervous condition, but if the allopaths don't know that, they'll give you Viagra. Said you may have time, I can correct that a couple of times. All right, so there's a little close-up picture of everything. All right, so everybody even closer up picture. There's a nice little picture out of Warren Daly. It talks about what each one of these fibers do. Valves of the heart. They're there to direct the blood supply. We already talked about that. And you can see how they're oriented. Now, do the pulmonary and aortic valve have a chordate tendon and papillary muscle? No. The pulmonary and aortic valve have papillary muscles and chordate tendon. No. Because there's almost no back pressure that would cause this to prolapse on the pulmonary side. And the aortic side just. Alright, so here we have our picture, our close-up picture of the valve, like I told you we looked at. So you have three tricuspid valves. You have a tricuspid valve on the right side, which is the right atrial valve. A tricuspid valve makes up the pulmonary valve. A tricuspid valve making up the aorta. And over here you have the mitral valve. Just two. Now, folks, I forgot where I got this from right here. But sometimes these valves wear out. Just common in bacterial endocarditis kind of damages the valve.
Can I ask a dumb question? What's the difference between a valve and a
A valve closes up. Sphincter just contracts itself. Okay, have a valve. It closes it right on that. All right. So sometimes these valves wear out, and they replace it. So you can use the pig valve. Pigs are very surprisingly close to us. You know, pigs are very close to us. We love pig parts. But you also have mechanical valves. And the problem, there's not a problem with deal with mechanical valves, is just like anything mechanical, it's going to wear out too. A lot of times, if you're young, you have to have one replaced. A lot of times, you might need to do it a second time. Of course, they say the pig valve might be the same way. but you also can hear them click. I bet you would click these every time they click. So you sit there in the bed at night, real quiet, hear this real quiet tick. Probably gonna be on watching. Really on it's very faint ticking. Because that's kind of cool. I've heard of this. Kind of cool. And it's very rhythmic, very. It's like a watch. All right, so here we are talking about the heart valve. I'll put you a couple of quizzes in. So you got this to look at, shows you the different directions of the blood flow. And here we are closer up, showing the valves and how they're directing the blood flow. The chambers, we already talked about that, have the septi between the two. You have a ventricular receptor here, atrial receptor here. And there we are just talked a bit about that. We're in the right ventricle. Right atria right here, the fossa valve, glandular valve. And I just talked about all this. So here's a little picture, closer up picture of the chorionic tendonitis and the papillary muscles. And you can see how they prevent prolapse of the valves. Prolapse can be very serious, and it can be something that gas is commenced in a pipe. Mitral valve prolapse, and most of you ladies in here will be commenced in a pipe. Unless you are, what you do, you hear a click, when it goes back up in the atria, you hear a click. Click. If you don't hear a click, it's not real, it's not real. But sometimes the prolapse is bad enough that blood connects to go back up in the atria, you will switch it. That is, that kind of indicates there may be something more to normally deal with an issue. But you'll outgrow. Most time when you have your first kid, you outgrow. All right, here's just a close-up picture of the ventricular coronary. This area right in here. That's called the conus arteriosus. Directs blood from the right ventricle up to the pulmonary back. If the heart was intact and been opened up, so you can see inside what it's called. And then you have the aortic vestibule on the left. And there's your little quiz you can practice. Now let's take attendance and we'll go over the arteries.
Too much. I just happen to have that one sitting around. Do you have a moment? Do you have any idea how to make the typing not make noise? Because I can't.
Oh yeah. Going into the setting.
Yeah, watch it don't take out the watch. You don't watch it. I'm back to some kind of. back over it now and finish up.
I was that so that.
Okay, now blood tests. So the heart has its own circulatory system, I was saying earlier. So to do that, you have to have arteries and you have to have veins. Some of which are named, some of which are not. Well, they are. So let's start right over here. So here's our ascending aorta. And coming off the ascending aorta, we have the right coronary artery. Right coronary artery wraps all the way around to the backside of the heart. It gives you a branch right here called the right margin. And margin just means running down the edge of the heart. That's all. Don't make a big deal about it. And you see here, some books you'll see this, some little stuff I got to do. You'll see a acute and obtuse. All that is the angle those arteries are coming off the horizontal. That's all they are. So don't make a big deal of it. So then we have our left coronary artery. Now right here you can see it's real short. Real short. It's actually covered up by the artery on the left side. Here's the right artery right here. Here's left. So the left coronary artery is actually going to take up the artery that it's in. And it's only about, maybe 5 millimeters, 5 centimeters, hard to get. 5 millimeters long. And then it splits and gives you the left circumflex coronary artery and the left anterior descending or interventricular. It has a couple names in it. And then over here, we have our left margin, or on the left side. And right here, as you can see how this runs, the right side runs around the back of the heart. It gives you a branch back here. You can't see it's not predominant, but you can see it right here. That is called the posterior ventricular. When you have all these other little branches right here, this right here is the left anterior descending artery. That's when we talk about being the widowmaker. That's it right there. You can see how it's supplying left ventricle. You have arteries going up to the atrium. All right? And some veins. So here we have the great cardiac vein, right? Runs along with the anterior ventricular. Fill up a little impression called the anterior ventricular septum. That runs around the backside of the heart. Then we have over here we have these branches right here. They're all branches of what's called the small cardiac vein. It's a little bit of right here. Here we have our small cardiac vein, our circumflex, our great cardiac vein. Then we have our middle cardiac vein. And we have a little inferior ventricular vein. That's fine. Something like that. But they all come together, the 3 main veins right here, come together to the coronary vein. And that is the coronary site. That's where the vessel runs. Because the heart is not as what it's not about. It has not anything to do with clogged arteries. It's there for protection. And down in the sockeye where the best part, you have your more factor. Has nothing to do with liking inside your arm. It's simply there for protection. As long as you're split cable, we got 0% body fat or crap. You have body fat inside, you have inside all of this one. All right, so there's a nice little picture of dextrose. There's your little quizzing right there. Another one right there. Blood flow to the heart. And there we go, blood flow to the heart. We've already talked about all of that. There's a little quizzing there. And here's just this kind of a schematic of your circulatory system. And that's it. Pulmonary circulation, we talked about that last week. So pulmonary trunk, pulmonary artery, pulmonary vein, making its way back to the circulatory system. All right, that's it. So I'll see everybody next week. Take care.